I'm Peter Block here in Washington, D.C. at ACC 17, and this is day 3 of ACC 17 and a quick wrap-up. With me on the far left is Kim Eagle from the University of Michigan. In center stage is Deepak Bhatt from Brigham and Women's in Boston, and I'm Peter Block, and I'm from Emory, and the three of us are going to see whether we can figure out what the top stories are from today. So the short version is we have 3 trials to talk about. I'm going to ask Kim to talk about ReCircuit. So Kim, give us the bottom line here.
So ReCircuit is a study looking at the use of either warfarin uninterrupted or dabigatran for patients having atrial fibrillation ablation. A large trial compared really looking at bleeding and suggested that actually dabigatran is superior to warfarin in patients who have atrial fibrillation. This is potentially a game changer for us because I think the standard of care right now is to use warfarin uninterrupted in these patients, and dabigatran looks superior, and perhaps the other direct anticoagulants are also superior.
You know, aren't we all getting sort of tired of warfarin? Isn't it time to throw it away?
I think it's time. I think we need new agents, and we have them.
Yeah, the data for NOACs across a variety of different indications looking pretty good.
Yeah, I know. It seems to me that
in fact, they're no longer novel. They're direct, right? I call them DOACs.
Yeah, okay.
NOAC sounds funny to me. I'm sticking with NOAC.
Yeah, okay.
Okay, no DOACs. Okay, moving on. Resolve and Savory, 2 interesting trials.
Sure. So I was involved, but these registries actually are getting published in Lancet as well. What they examine are patients with TAVR, but also SAVR, that is biological valves, and the rate of subclinical leaflet thrombosis. So the same group had previously published in New England Journal subclinical leaflet thrombosis with TAVR valves. Now we're showing it actually happens with SAVR valves, and potentially importantly, it seems to resolve with warfarin and with NOACs as well. Now, what the clinical implications, this isn't a randomized trial, it's a registry, we don't know. That is, I'm not saying put a 90-year-old on anticoagulation if they don't have another indication for it, but it does raise the possibility that perhaps instead of doing DAPT, for which there's no data post-TAVR, maybe we should be doing anticoagulation. And there was, I'll mention, an association with the composite of TIA and stroke, and also for TIA, not for stroke alone.
Yeah, there is a trial going on, the Galileo trial, which is
Yes.
rivaroxaban in patients who are having transcatheter aortic valve replacement. We'll see how that one comes out. I think that will be an important trial. The bleeding issue is always going to be a problem, particularly when you get into the aged population.
Right.
People in their 80s don't do well with anticoagulation, even NOACs or DOACs, whatever they are.
Big calcified vessels, lots of bleeding.
Yeah,
Absolutely.
That's the problem.
So, yeah, don't want to be cavalier in overinterpreting the data, but I think it does open up a lot of avenues for research. Like Galileo, there's a corresponding European trial as well that's looking at the issue.
And if you see it on transesophageal echo, which is the best way to see these abnormalities, is the good news is they go away.
Yes, with anticoagulation they do, and it appears that's true of NOACs also.
Yeah. Okay, so let's move on to, this is an interesting issue, the embolic protection after surgical whatever that the surgeons are doing, aortic valve replacement or coronary bypass grafting, whatever, embolic protection during the surgery. Do you want to just chat about that a little bit?
Sure. Well, what this study shows is clearly if you look and retrieve, you find. I mean, there's a lot of stuff there. And it's similar, I guess, to even embolic protection with TAVR. But I think the harder part is in the absence of clear impact on hard outcomes like stroke, exactly what to do with it. Now, any of these trials, you don't see a lot of strokes. None of them can ever really be well powered for it. But I do worry a little bit about whether, silent microinfarcts of the brain are sort of like small peri-procedural MIs. I'd rather not have one if I could prevent it, but on the other hand, how much are you willing to pay for it?
Any comments, Kim?
Well, I think the other part of this is this debris ongoing? Not just during the procedure. So you catch it during the procedure, but how much continues to go after the procedure? Yeah. If that's a lot of it, then we're going to have much harder.
Well, I think the answer is don't shake your aorta.
Totally.
You try not to do that.
Leave that thing alone.
Okay, but the interesting thing about that trial is they showed that they had debris that was parts of the valve, it was part of the base of the aorta, it was atherosclerotic debris, all kinds of junk that they picked up in these embolic protection devices.
But do you remember that older study, I think it was in The Lancet, where just crossing an aortic valve would send debris to the brain, silent debris.
Yeah.
And at least at Cleveland Clinic where I was at the time, we stopped routinely crossing valves after we read that. Up till then, we always crossed the aortic valve.
But you know,
there's always stuff going up to the brain.
But post-op, post-pump, there are always patients who tell you, you know, I can't do my math as well.
Right.
And that post-pump syndrome, I think, is probably the result of all this.
I think it's at least part of it.
Yeah, and so the question is, even though these trials are negative, we can't prove that it's bad for your brain. It tells us your brain is A, more resilient than we think, and B, we don't know the long-term outcomes.
We have a long way to go in this.
Yeah.
Or have PCI instead of cabbage.
Yeah, well, I don't know. The PCI can still do it, I think. Be that as it may, that'll be the wrap-up for day 3. Thanks, folks, for being with us, and that's the end of day 3.